Hello, fellow DOT students. This is Dustin, and I'll be talking to you today about the acute effects of instrument-assisted soft tissue mobilization for improvement of posterior shoulder range of motion in collegiate baseball players by Laudner, and it was from the International Journal of Sports Physical Therapy, February 2014. All right. A little bit of background. As we all know, just the repetitive overhead motions of baseball can lead to limited glenohumeral range of motion. And for the purpose of this presentation, glenohumeral is just going to be GH and range of motion is going to be ROM. These limitations can usually be soft tissue or bony changes from the excessive overhead movements in baseball. And Graston's technique has become pretty popular and can be used to address any soft tissue type of restrictions in the muscle. All right, the purpose of this study was to determine the effectiveness of instrument-assisted soft tissue mobilization in improving acute passive glenohumeral adduction and internal rotation in collegiate baseball players. Methods. This study utilized a blind randomized design in which participants were assigned to either an experimental group, which was the IASTM, or the control group. 35 collegiate baseball players volunteered to participate in this study, and it's important to note that the inclusion criteria was that they had to be a NCAA Division I baseball player on one of the teams. No recent history within 6 months of upper extremity injuries or previous upper extremity surgeries in the throwing arm. And you can see from the chart, these patients were randomly divided into the groups, and the number of each in the group is in the chart in Table 1. You can see the average age, height, and mass. All right, methods. The independent variable was the Graston's technique applied to the posterior shoulder. The dependent variable was the GH horizontal adduction and GH internal rotation. Figure 1 shows how they measured GH horizontal adduction, and they used a Pro 3600 digital inclinometer. Sorry, I'm pretty sure I just butchered that word. To measure these ranges of motion, and according to the manufacturer, it was accurate to 0.1 degree. In Figure 2, you can see how they measured glenohumeral internal range of motion. It's important to note that the time between pre-test and post-test measurements for both groups was 90 seconds. So what they would do, they would take a measurement, then they would do the Graston's technique. Graston's treatment was applied for approximately 20 seconds in a direction parallel to the muscle fibers being treated, with the instrument at a 45-degree angle, followed immediately by treating the muscle in the directions perpendicular to the muscle fibers, with the instrument at a 45-degree angle for an additional 20 seconds, resulting in a total treatment time approximately of 40 seconds. And they did a intertester reliability of passive range of motion measurement prior to the study, and they found an ICC coefficient of 0.93. All right, so the results, you can see that there was a good effect on improving the posterior shoulder range of motion with using the Graston's technique in Table 2 with both GH horizontal adduction and GH internal rotation. So clinical application, just a personal thing, I've always been interested in the Graston's technique, but what's really stopped me from using it is the cost of the class and the cost of the tools itself. That's sort of been the biggest thing for me not using it. I think there is a place for like soft tissue manipulation with tools in clinical practice, but the classes and the certification sort of are the limiting factor for me. If your employers are willing to pay for the CEUs and the classes and instruments, I think that would be a great thing for clinical application.